Hello, everybody, and welcome once again to the Wednesday night webinar sponsored by NoCD. NoCD is a downloadable free app through the iOS or Google Play Store. NoCD has teletherapy available in 24 states currently, and over 80 clinicians who are ready to meet with you and see how you're doing. And we're continuously working on taking insurance. So that is just a constant upgrade that we're doing across the country, is working with insurance companies. If you want more information, you go to treatmyocd.com, or if you'd like to speak to one of our intake coordinators to see about teletherapy with NoCD, you can click on that link through the other side of Dr. Pollard's head there, and then you could click on that blue link up there in the yellow box and schedule a free 15-minute call. Tonight, it is my pleasure to welcome Dr. Alec Pollard from the St. Louis Behavioral Medicine Institute. And we've known each other for 20 years now. Oh. Actually, it is 20 years. Yep. Alec Pollard was my postdoctoral supervisor and maybe the person to blame for why I do what I do. Well, blame might be a good word for this whole experience, but I knew about a week into postdoc that this is what I was going to do for the rest of my life, was work with anxiety disorders and OCD and everything, and it's just been a joy ever since, and we've stayed connected and buds through the whole experience and everything, so it's great to have you here tonight, Alec. Thank you very much.
Delighted to be here. Thanks for having me.
Alec, you want to tell everybody a little bit about the St. Louis Behavioral Medicine Institute and what you do there?
Well, I wouldn't know. I haven't been there for quite some time.
Oh, this is true. Yeah.
Actually, well, we're all working, well, not all, but there are a few people that are on site, but most of us are off site. I'm in my lovely home office tonight. But St. Louis Behavioral Medicine Institute is a fairly large group in St. Louis of about 75, 80 clinicians who each belong to a specialized program. So our main niche is specialized programming. So, of course, I direct the OCD and anxiety program, but we have an eating disorders. We have a special program for impaired clergy. We have a health psychology program, neuropsych, and women's health, and child and adolescent. I hope I didn't forget any. I'm going to get in trouble. But anyway, it's a bunch of specialized programs, and we're very proud of the Institute. And we have joined you in the world of telehealth by necessity, and it's turned out to be a godsend for a lot of our patients.
Yeah. Normally I don't jump into the Q&A, but a question just came up, which is, what was it like to teach Dr. McGrath, and what were the challenges?
How long a show is this? I thought it was less than an hour.
Yeah.
I will be doing a workshop next week. It's a 3-day training on how to deal with Dr. McGrath. It's very, very challenging.
Yeah.
It was a lot of fun. He's got a good sense of humor, and occasionally I like that. So we had a lot of fun when he was there.
Yeah.
And I would say that Dr. McGrath was always one of the stars on our annual productions at the annual party where we entertain the rest of our colleagues.
Yes. Well, that was always a great time. So now our format is typically this, where we're going to get into some of the Q&A and people are going to load questions, and we're going to run through a bunch of things here. But there's a couple of things that I'd say you're really well known for, especially in the last decade or so, which is really taking a look at treatment interfering behaviors, which I think are a great discussion for the people tonight on our webinar, and also family accommodation and helping families figure out how to not be so accommodating to people and their anxiety disorders and giving them safety behaviors. So let's start off with treatment interfering behaviors, because those are things that come up all of the time on the webinar. And I'd like to hear from you a little bit about what's the current thinking about treatment interfering behaviors, or TIBs, as you also call them, and what are things for everyone to kind of look out for, and how might they know that they're using a TIB?
Well, as I understand it, we have therapists listening, but also people who are have the challenge of having OCD. And,
correct.
And this is relevant to both of them. In fact, I don't know if you know, I'm working on a book about TIBs. I don't know if I mentioned it to you or not, but
okay. Well, you don't like me anymore, so you didn't.
I don't. That's it.
Okay.
Okay, I'll do a gratuitous plug, but there's
Please.
a book coming out called When Therapy Doesn't Work. And it looks at the reasons that therapy doesn't work in some cases for some people. And one of the major reasons is treatment interfering behaviors, or TIBs. And I like TIBs because they sound less, mean. TIBs just sound so friendly.
Yeah.
But it bears talking about a little bit about the nature of TIBs, but also how we need to approach them. Because, and I want to say this up front, my belief is that yes, patients come in and they have treatment interfering behaviors. These are any behaviors that can interfere with successful ERP or whatever the treatment approach is that a person is trying to implement. And that could be anything from not doing your homework assignments, missing sessions, showing up late, arguing with the therapist. I find that particularly upsetting. And sometimes I have to lie down after my patients disagree with me.
Mm-hmm.
There's many other types of, but it's any behavior that's inconsistent with effective participation in treatment. And there's different categories. There's things that interfere with communication. There's things that interfere with problem solving, things that interfere with focus, staying focused on the problem, and then things that interfere with follow through. So I've developed these 4 categories of TIBs to help people understand how they might interfere. Now, here's my stance on this. If you are a patient and you come to me with a TIB, it's my fault if I can't help you deal with it. It's not yours.
Mm-hmm.
You didn't decide to have TIBs. You didn't decide, and TIBs are caused by really known factors that we know affect human behavior. TIBs are not signs of willfulness or laziness or any kind of character flaw. They're driven by, and maybe we can get into that more, a number of factors that are real factors that make people behave in ways that are actually self-defeating. And so the TIBs, people can have a lot of shame about TIBs or feel like somehow they're bad. And that's not the case. They can't help it if they have extra burdens in addition to their OCD, and it's our responsibility to figure out how to help them with that.
Well, that's great, because a question just came up about advice for feelings of shame. So shame being a big piece of this, that I might feel bad that I'm not doing the things that I'm supposed to be doing in therapy or the suggestions that my therapist has made. But as you said, but I've got these other things in addition to OCD that are also going to be a part of the work that I have to do.
So the first thing I would do is, now shame is something that we might consider a driver of TIBs.
Yeah.
So what we first look at are, what is the behavior itself, and objectively describe it. Do you, are you a yes butter?
Mm-hmm.
I think most people know what that is, and that's an interference with problem solving. So when you and the therapist try to solve the problem of, why aren't you doing your homework? Let's try to figure it out. And then as the therapist may come up with ideas, the patient may say, yes, but, yes, but, yes, but, and without offering an alternative idea. So at the end of the discussion, there's no ideas left there. That's an example. So, but we start with the behavior first, and then the patient and myself, or whoever the therapist is, has to agree on that it is a TIB and that it is interfering.
Okay.
Then we go to what's driving the behavior. So shame might be one of the things that drives the behavior. So one of the things I'd want to know from the person who shames themselves or feels that shame is, how does that lead you to behave? And does that interfere with treatment? I suspect it does. Because, for example, if it leads you to put yourself down, and this is a very common thing that patients do, when, like if they didn't do their homework. So they'll come in and they'll be shaming themselves between the waiting room and my office. Like, oh, you're going to kill me this week. I really screwed up, blah, 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 blah. And that is actually not useful, because that, excuse me, I've got something on my screen there. Just got rid. Nobody else saw it, did they?
Well, just me, but let's
Okay.
hope nobody else
I need
saw
to
that.
talk to you after the session, but
Yeah, yeah.
so so shame. I would want to know how you behave when you're feeling shamed, and how that might interfere with it, and then we would practice alternative responses to those behaviors. You can't will yourself not to have shame. What you can do, though, is begin to practice behaviors that are incompatible with shame behaviors. And and just like every principle in CBT, you do the behavior first. Well, first you get the insight, then you get the behavior change. The feelings then come later.
Is procrastination a TIB? Is a question that just came up.
Absolutely. Well, it's also a symptom, but yes, it's a TIB. However, if you're talking about your therapy assignments and homework, if you get them done by the time you're supposed to come into your therapist, then it's not really interfering with treatment. It's delaying it, but as long as you're keeping up, even if you're not as efficient as you could be, yes, it's a tip. But if you're procrastinating so much that you're putting things off and you come into the session and say, well, I just didn't have time this week, or I wasn't ready to do it, yeah, that's interfering with treatment, because now um, you've lost a week. Now, it's not really a loss if you and the therapist sit down and figure out what happened and try to develop an intervention for it. It's not loss, it's learning.
Right.
But if you don't, if you just leave the session and say, I'm going to do better next time, gosh darn it, like the proclamations of perfectionism, what I call them,
Yeah.
I just got to put my mind to it. That's not an intervention. That is nothing different than what you did the week before. And you're probably going to be doomed to repeat it. So make sure that when you leave the session, you do one of two things. You either make your assignment easier, or you add an intervention that's really, truly different than what you did the week before. Otherwise, you risk wasting another week.
I've sometimes called that crisis of the week therapy, where shockingly every week there's some new crisis that prevented me from doing the work that I needed to do. And many therapists can get derailed into going and focusing on the crisis, and then at the end saying, now go back to doing what you were supposed to do. And shockingly, there's another crisis the next week. Then.
Well, so that we would put that in the category. That's great, because I'm working on these categories. So so that would be the category of interference of follow through, right?
Okay.
Or focus, because it's distracting you off of the focus. By the way, not intentionally. The person's not trying to do that. It's just the effect. Right. I should emphasize that the TIBs are defined by the effect of the behavior, not the intention. Nobody's trying to goof up their therapy. That doesn't happen. Okay, there was one guy in Montana.
Well, there was that guy.
Just that one guy in Montana. Everybody else, no, they don't do it. So it's the effect of it, and that's really the critical thing. Yeah.
And how about alcohol and drugs? Would those be considered TIBs if they're being used as a way to deal with anxiety and discomfort instead of doing ERP work?
Well, I want to distinguish between avoidance and TIBs.
Thank you.
Just simply avoiding something is part of the syndrome. And some people may use alcohol to avoid having bad thoughts or feelings associated with being triggered or whatever. So alcohol, substance use becomes another part of the disorder, in the sense that it's just another avoidance behavior. And I don't consider that a TIB by itself. Now, if I try to help you with your substance use and you yell at me, or you walk out of the room, or you don't show up the next session, those are TIBs.
Right.
Yeah.
One, I like this one. I cannot stop thinking about work, and if I do something wrong, something bad will happen. And the word cannot is capitalized. And so that leads me to think that maybe not necessarily a treatment interfering behavior here, but a goal that's not maybe the best goal, which is our goal really isn't to stop thinking of it. It's about learning that we can handle thinking about it. And so how do you help people kind of distinguish between those types of things where my OCD tells me I have to 100% not think of something, but the goal of therapy is to be okay with the fact that I might? right?
Well, that's actually that's another great example of trying to make distinctions between what's really a TIB versus part of the syndrome. Um, if part of your syndrome is you're trying to create an internal state, a thought or a feeling, and you're trying to will that upon yourself, or get rid of a bad one, or will a good one inside of you, that's part of your syndrome. That your inability to do that is not a TIB.
Right.
It's you're human. Now, if I try to work with you with a realistic way to help you learn how to stop doing that, and your behavior interferes with my ability to teach you that or to help you do that, then that's a tip. So, for example, if I try to teach you an alternative way to think about your problem, just like what you were saying, Patrick, was like, okay, the problem is it's not that you can't control your thoughts. It's that you have to learn how to ignore those thoughts and move on and not stop them, but just let them go and learn how to refocus, for example. That would be a different way of understanding what your task is. And if I am trying to explain that to you and you're arguing with me or you're not listening or you're whatever, that's a tip.
Mm-hmm.
The symptoms of the disease are not a tip. It's how you approach it, how you communicate, how you problem solve, how you follow through, and how you focus.
Now, are you saying that sometimes someone might not want to listen to something you say, Dr. Pollard?
It's hard to believe, I know. But if you would like proof of that, get my wife. She's right here.
Heidi.
She'll come right in.
She was, yeah.
Tell you why she shouldn't listen to me.
Now, some of the questions that have scrolled through, I'm kind of keeping an eye on them at times. Is there one TIB, especially in OCD, that maybe is the leader of the pack, so to speak, or one category maybe of TIBs that you see more common than others?
Well, probably, and we have the most research on this too, is adherence or non-adherence. So
okay.
Basically not doing your therapy, not your homework assignments.
Okay.
Is probably the number one. And I want to be clear, I'm in the midst of writing this book, so there may be new terms coming out of my mouth that as I'm writing this book, but we could make a distinction between treatment interfering behaviors, which, by the way, almost everybody has. I want to be clear that my dentist considers me a guy with treatment interfering behavior.
Because you don't floss every day.
Exactly.
Yeah.
I don't. And would you please not say that? Thank you.
Sorry, Mr. Dent. He flosses all the time. Don't worry.
I got bloody gums for a week. I never fool him though. So treatment interfering behavior is ubiquitous. It's everywhere. We all do it. It's just that for certain kinds of behaviors, for certain individuals, it has a bigger cost.
Sure.
And so, and in some cases, actually prevents therapy. So I would say that, so everybody has trouble doing their homework, and we'll call it a TIB, that's fine. But it might not need special attention. But if the TIBs are so persistent and severe that you really are not making progress because of it, then it really is a good idea to stop the OCD treatment and switch to working on the TIBs for a while and then go back to the OCD treatment. I think you'll find that it works a lot better.
Yes. I'll get to that in a moment.
Yeah.
But just a reminder, welcome Wednesday night webinar with Dr. Alec Pollard from the St. Louis Behavioral Medicine Institute. Our weekly webinars are provided to you by NoCD. NoCD is a downloadable app that you can get for free. And if you are interested in teletherapy in 23 different states where we could potentially utilize your insurance, as we continue to work on doing, you can book a free 15-minute call with our care team right through the head over there and in that little blue link, or go to treatmyocd.com. I've often said, I'll take it outside of psychology for a minute. I said, if your goal is to become a piano player, but you only play the piano during your lesson, you only get half an hour better a week. Yeah. And we could see that in therapy as well too, that can happen as well. Yeah. I've always liked your concept, especially when you use your favorite example of Mrs. McGillicuddy. She's always doing all sorts of interesting things.
That poor lady.
That poor lady, yeah. But you've always kind of taught me that idea of a therapist is good at falling on their sword and not blaming their patient, but at being able to walk into a room with someone and say, Mrs. McGillicuddy, I just want to apologize. I finally realized what's happening, and I didn't recognize something. And I'm so excited now to say to you, this is what we're going to do. Mm-hmm. And I'm amazed every time that I do that still. When I say to a patient, I know you've come here for OCD treatment. We finally identified a treatment interfering behavior. We're going to stop doing any kind of ERP because you haven't really been doing it any. We're going to switch to treatment interfering behavior. They start arguing saying, oh, no, I really want to do the ERP. Right? Do you get that as well?
Oh, yeah. But if they are in that category I was just mentioning, where the TIBs, I've concluded that the TIBs are so severe. I just want to be clear for people listening. Just because you have TIBs doesn't mean you're in this category.
Right.
The TIBs are, I call it treatment prohibitive behavior. That the TIBs are so persistent and severe that you really can't progress with the TIBs unchanged. And you need to work on those TIBs. Most of the time they can be managed by the therapist, problem solving. Well, let's figure out how to do this differently. But when they can't be, it really needs to be addressed straight on. And you're absolutely right. We as therapists have to take full responsibility for this. It is not their job to not have problems. It's our job to figure out how to solve their problems. And so when I say it's my fault, I'm sincere about that. Mm-hmm. I really do. Now, it happens to, most of the time, make them feel better and less defensive, less shaming. But that's not really the reason I'm doing it. It's a nice side effect of it. But it is really our responsibility to figure these things out and try to help people get around these impasses that they run into.
Yeah. The other piece then that I want to get to, and then we'll go into some of the Q&A piece of it, is family accommodation. And this is another area that you've done a lot of great work in. I know that people from all over the world have called you to say that their husband, spouse, son, daughter, child, mother, wife, whatever, has OCD and really is refusing any therapy. And you've kind of taken on a job to help kind of coach them a little bit through how can you get them to start working with this person, even though this person doesn't want to change. So I'd be interested in you sharing with our audience about what that work is like, and what are some of the things that you have suggested to families when there is someone who's stuck and doesn't want to change, because we usually have some family members on the list that happens. And,
sure.
And what are some of the pieces of advice you would give to those families?
Sure. So that was many, many years ago when we first, we'd get these calls, and I felt so bad for the families that they were suffering, and they really are often the neglected victims. And they were suffering from a person who had OCD or hoarding or whatever related disorders, but wouldn't acknowledge the problem, or said it's a problem, but refuse to go get help. And so at least if you got treatment interfering behavior, that means there is some treatment being attempted to interfere with.
Right.
But these are treatment refusers, or folks who will not go get help. And the families are left to struggle with this awful burden in many cases. And so we felt bad, because what most therapists will say to them is, I'm sorry, there's nothing I can do if your family member doesn't want help. Just have him call me when he wants help. And okay, how does, then we see these families are just suffering. So we decided to try to do some things to help the families. And if nothing else, we can help the rest of the family, and maybe in the process we might be able to create some forces to move the person with OCD towards therapy. But even if we didn't accomplish that, we can improve the quality of lives of the rest of the family, as long as they're willing to work on it. And so we started developing some procedures, inviting families in, and then we did a study and learned some things from that study, and then we modify our approach, and now we are, I know I'm just touting another book, which both books hopefully are coming out next year. The Family Trap, a guide for those with a loved one who won't seek help.
Is
And
that the Von Trapp family or the
it's not the
family?
Von Trapp family.
It's
No.
not. Oh, it's not the Von Trapp family.
So in our approach, we I just be very brief, but our approach is called the Family Well-Being Consultation, and the emphasis on family well-being. We're not just concerned about getting somebody with OCD better. We're concerned about improving the lives of everyone in the family and anyone who's interested in having their lives improved. And so because the influence of the OCD, the tentacles of that octopus go way beyond the person with OCD and affect the lives of so many people. And if family members can't extricate themselves from the OCD, how do they expect the person with OCD to be able to do it? So we teach them how to take themselves out of that web. And then, and only then, when they take themselves out of the web, we will teach them strategies that are more effective at actually perhaps promoting recovery seeking in the person with OCD. But we won't do that until we're convinced that they've taken care of themselves first. And the old metaphor about being on the airplane, and when the oxygen mask comes down, they don't say give it to your child. They say give it to you. Then once you're stable, then you give it to your child.
Yeah. Yeah. And I've seen so much of the heartstring experience, and I'll just say to you something just for an example of our audience might say, but Dr. Pollard, my child has nothing left anymore. They have no friends. Nobody calls them. They're miserable. And if we take away doing all of these things for them to try to make their OCD go away, what if they harm themselves, right? And how do you deal with that?
Well, that's a great example, because one of the things I would say is that okay, I got to see if I can quote myself here, but
you have such great quotes; it's hard to remember.
It's a great quote, and I can't do it spontaneously. But basically, it's not, families fail in this situation not because they don't know what to do or they don't have some good ideas about what to do. They fail because they try to do those things before they are emotionally and strategically prepared.
Ooh, I like that.
And one of the things they have to be prepared for is the sabotage behavior of the individual as they react to the things the family are changing. It's not always going to be something that's not scary.
Right.
They could talk about suicide. They could become physically violent, and the family has to know what they're going to do if that happens. And not only do they need to know it, they need to tell the person what will happen if that person does these things.
Yep.
And because what happens is they start to do something, they try to get tough, and they're not ready emotionally, and then the person with OCD reacts, and I get why they are reacting that way. They're scared to death. Mm-hmm. And so they react in some dramatic way. It scares the family. They all pull back, and now the family's lost credibility. For the next time they try to draw a line in the sand, and the patient feels misunderstood, not heard, and it's just not a good way to approach it. And so the family well-being approach is very, very different, and not unlike what we talked about, where the family takes responsibility for nagging and lecturing the person and pushing them, and pulls back and creates an atmosphere at first of less tension and conflict, and then gradually starts to build influences on the behavior of the person with OCD.
Mm-hmm. I'd add one thing to that too, that I've noticed, that when the family doesn't follow through on that, the OCD learns, now I can go this far. And then the next time they don't follow, now I have to take it this far. And the OCD is just it's so opportunistic that it will take it as far as it possibly can to get what it wants.
That OCD is greedy, not the people with it.
No,
but OCD is greedy.
Yeah, it's the hungriest thing I've ever seen, and I've never seen a satiated OCD. I've never met a patient with OCD who said, I've finally done enough compulsions now. I'm good, thanks. That's not happened. I don't think that's happened to you either.
No.
So definitely not something that's going to occur. Well, thank you for those explanations. I think that they're wonderful. And welcome once again, everyone, to our Wednesday night webinar. We're here with Dr. Alec Pollard from the St. Louis Behavioral Medicine Institute in lovely St. Louis, right across from beautiful Forest Park. Lovely, lovely area.
Yeah.
And enjoyed having my postdoc there for 2 years to be with Dr. Pollard. And OCD is available for teletherapy in 24 states. So look us up on treatmyocd.com. Dr. Pollard, I'm going to go through some of these interesting comments that we've seen. One I thought was funny was your opinion on the band Rush was one comment that I thought was pretty good. Of course, you think they're the greatest band ever.
I was going to say that.
Yeah, of course you are.
Yeah, for years I thought you liked the band Thrush, and I couldn't understand.
It was just a little thing in my throat. That was that's all
right.
it was. Yeah. So let's see. Let me pull up some questions here. So, so advice for difficulties resisting mental compulsions. And sometimes this is labeled, of course, as pure O, but this is probably one of the most difficult things for even clinicians treating OCD too, is working on the mental compulsion piece. So this person says, I often hear from patients that mental compulsions follow the intrusive trigger so fast they feel automatic and as if they can't control it. When a compulsion is a self-statement or some form of thinking, how do they resist or not think something? For example, intrusive thought, what if I don't love my husband? Instant compulsion, tell myself that love is a choice or check my emotions for positive feelings toward him.
Now, I was told that there would be no difficult questions.
Oh, I'm moving along.
Okay, thank you very much. Okay, so we're off of TIBS a little bit, which is perfectly fine. I love talking about OCD just in general. So I think everybody probably knows, or a lot of people know, that pure obsessionals was a misnomer that people used to think, because they didn't recognize that there were mental rituals. They thought, well, these certain patients don't have any compulsions, and they were missing the boat. And we have to always use pure obsessionals with quotes around it,
always.
Because that term has gotten out there and we're stuck with it. But
yeah,
it's really a misconception. Of course, they have compulsions. You can't have OCD without compulsions, and I don't care if the DSM allows for it. I've never seen it. No one's ever seen it. No one I know. I know, Patrick, you've never seen it.
I've never seen it. And I've always wondered why that's in the diagnostic manual, that it says that that's a possibility. Or somewhere in some research, someone said they found like 0.5% of people who didn't have compulsion. I've never met any of them.
I can tell you where it comes from. And this is, I'm saying with great arrogance, and I have no idea, but I'm going to say it like I really know. There are some people who were on the committee and the DSM who don't do a good evaluation and diagnostic for the detail and depth that we do.
Okay.
Cognitive behavior therapists. And they just didn't ask. And so they think those patients don't have compulsions. But anybody I know who is a cognitive behavior therapist who looks for mental rituals had never told me, an experienced one, that he ever saw anybody who didn't have it. And theoretically, it makes no sense.
Right.
If you had obsessions all the time and you didn't do any compulsions, you would have accommodated to it.
Right.
Because you wouldn't be avoiding.
Right.
It is the compulsions that keeps it active. Well, okay. Yeah. So back on to the question about, I understand that mental rituals can seem so automatic, and I wouldn't even argue that they aren't in some way. So a couple of things to keep in mind. You can't, first of all, you don't stop doing a mental ritual. You do something that interferes with the mental ritual, and that's much easier to do. So I'm just doing a simple thing. So let's say my bad number, if I have a bad number or a number that's soothing to me, like 777, then I'm going to say 888 to goof up 777, so I can't get that satisfaction. Don't say 7. All right, say 8 instead of 7. And that is what will help. That helps you not do the compulsion. The same is true that's how we use coping scripts. That we use coping scripts that teach you what to do with your mind rather than do the compulsion. And so it's a lot easier to do that than to simply not do the thing. And the final point I would make is that when you do planned exposures, you are ready and set. You're thinking about it. You got your coping strategies ready. You trigger yourself, and that automaticity argument is gone because you are already prepared to do the thing you're supposed to be doing rather than that. I understand that during the day you get blindsided. We don't expect you to be good at that right away anyway. Our first focus is on what you do during a planned, structured exposure. And if you've got to be able to break that pattern under those conditions before you even dream about doing it spontaneously. So first focus on these planned, structured exposures and being ready, have your tools in place, and then you will have some agency over the process.
I've always liked Doug Wood's examples of working with people who have tics, who we thought for years that tics were just uncontrollable. There was no, and then he and his colleagues started showing you can intervene in a tic and you can do an opposite behavior and everything. So I think it's very similar to this. Maybe nothing is actually just automatic. We just have to be good investigators to figure out where we can slip something in as we do the work.
Yeah, no, that's a really good point. And it's not a bad model. And by the way, again, if we're perfectionistic, which no one listening to us or either Patrick or I are perfectionists, we just want to be clear in case any of us meet somebody out there that is. But if you're perfectionistic, then you're all or nothing sometimes. And so if I can't control it and then I'm failing. No, if you've been doing it for 5 minutes and catch yourself and stop it in the middle, you're making progress. So it's what is feasible under spontaneous conditions is catching it as early as possible and then redirecting your attention onto the thing that you've been told to do that's different and incompatible with the compulsion.
How do you recognize when you're avoiding intrusive thoughts as a compulsion rather than ignoring them? Wow, now that's a great question. And boy, sometimes, I'm going to throw a few things out of that sometimes that's a rabbit hole argument to not do ERP in the session. Could Dr. McGrath, can we just talk about this for the next 20, 30, 50 minutes maybe and see versus does it really matter or should we just start doing ERP and see where we go is one potential way of looking at it. But I'd like your opinion on that as well.
Yeah. Well, let me make sure I understand the question though. It's can you rephrase it for me?
How do you recognize when you're avoiding intrusive thoughts as a compulsion rather than just trying to ignore them?
Oh, okay.
Because I don't think we ever try to ignore them, right? I'm more of we accept them and we move on, not trying to ignore them.
Yeah, ignoring our language, our English language is not perfect
right
to describe these things because sometimes we're meaning the same thing, we're using different words. But I would put it this way that there's active neutralizing, which is a compulsion, right? So I get that thought, and now I have to do something to neutralize the thought. To take its power away. That's a compulsion. That's the worst. On the good end is I immerse myself in the trigger. I welcome it. I lean into it. Give me your best shot, and I don't try to neutralize it. That's what we really want during those planned exposures. The rest of the day, and this is where I think we have to understand that the rest of the day, if you mean by ignoring, just redirect your attention. Not neutralize it, but simply redirect your attention onto what you're doing. That's actually okay, as long as you're also doing ERP part of the day. Mm-hmm. Because you can't do ERP 24 hours a day. If my ERP, if I'm supposed to process a bad thought, focus on it, close my eyes really, and maybe have a coping script going and whatever, so that I'm not neutralizing. If that's my thing and I'm in a business meeting and I get triggered in a business meeting, I'm not going to go, hey guys, give me about half an hour. I got to go close my eyes and process. And you guys talk about the Johnson deal without me. Yeah. You got to, but what's a good adaptive in between is to notice that it's OCD, just like Jeffrey Schwartz says in his book, notice it and redirect your attention on, and Schwartz was right that was a good thing to do when you can't do ERP. Just missed that ERP part in his book.
Yeah, you saw the Schwartz questions that were there right then. So
I didn't, but it's just natural.
Well, actually, here, so let me go back just a little bit. We had a couple of questions about that. So it's interesting that you brought it up.
Well, when you're talking about ignoring thoughts, you think of Schwartz.
Yeah.
So Schwartz made a mistake by saying, while you're looking for it, he made a mistake by saying that the therapy is really just kind of redirecting your attention and calling it OCD, and there was no research to support that whatsoever, and he was appropriately criticized for that.
Recognize, relabel, refocus, and revalue.
No, that's good 23 hours a day, but not in the 24th hour.
Yeah.
In the 24th hour, you damn well better do ERP.
Right.
And if you want to get better. So if you want just a simplistic way to think of it, exposure gets you better. ERP. Got to have all three letters.
Yeah.
Avoidance makes you worse. Refocusing doesn't get you better, but it doesn't make you worse.
Mm-hmm.
And so a lot of the day you're going to tread water so you don't lose track, and then you're really going to make the progress when you're doing real head-on ERP. That's how you're going to make progress. But generally, there's no evidence that simply refocusing, like Schwartz says, by itself will get people significantly better.
Yeah.
It's better than doing compulsions, don't get me wrong.
Mm-hmm. And you've always said, and you stressed this significantly when I was training with you, exposure without response prevention is kind of a waste of time, right? That It's just not going to get you where you want to go.
Well, one of my favorite titles for one of my talks was a realistic formula for ineffective therapy: E minus RP equals 0.
There you go.
Yeah, and so I felt like I was Einstein during that time. But
well, like many people have felt that about you as well.
Jimmy Joe Einstein.
Yeah. Einstein's long lost cousin, and Jimmy Joe.
Not real sure.
Okay, let me pull up some more of the questions here. I like this one actually. Can rage be a part of my OCD? Constantly trying to align things or put things in order, but never really getting there 100%, and then I freak out. What can one do to relieve anger when things aren't getting done the way your OCD wants it to be done?
Well, one would be get better.
That's a great piece of advice. Yeah.
But I know, I'm sorry, that was snarky for me. Because people react to frustration caused by triggering an OCD or their frustration with the compulsion not working or not getting it right and having to keep going back and back is unbelievably painful and frustrating. But people vary in their propensity to react with rage or anger. Everybody gets frustrated, but some really do have very strong rage reactions. And now, interestingly, if we think of rage as anger actually inhibits anxiety. And so sometimes people will say that after they have an outburst of anger, they actually feel less anxious. And the reason that is that if you think about the fight and flight response,
mm-hmm.
That you get triggered, you either are preparing to fight, which is going to be anger more, or mm-hmm. flight,
which
fear,
is more anxiety.
Get away, mm-hmm. right? So actually, and this is an interesting side story that maybe some of the therapists will think is interesting. The patients will be yawning, but
they've probably been doing that already. So
yeah, Joe Walton, who was my mentor, one of my mentors.
Yes.
He was a father of behavior therapy, but he invented assertion training. But in his mind, he wasn't teaching a skill. He was doing it for them to generate anger to be a reciprocal inhibition of anxiety. Because research was showing in lab animals that when anger was induced, their anxiety would go down. So, at any rate, just
and reciprocal inhibition being that idea that you can't have two competing emotions really going on at the same time, right?
Either anxiety or something else going to be dominant. So, but there are things you can do separately for rage management. It depends on how big a problem it is, but actually there are things like distress tolerance and strategies to tolerate some of those negative feelings so that they don't overtake you. And the main thing is not behaving in a way that actually causes more problems.
I've often liked the idea too that I say to my patients, nobody does anything without getting something out of it. So your anger is serving a purpose in this kind of experience. And you may be frustrated by it, but you wouldn't have the anger reaction in the moment that you have it without benefiting from it, even if it's just for a millisecond or two, right? But there's still something that you're getting out of that. And maybe it's what you said, when I'm angry, I'm not anxious. So at least I'm not feeling the anxiety.
Yeah.
And that could be it. Yeah. All right, next one. Often I don't know whether an action I'm considering doing is my own decision or actually a compulsion. It can be incredibly difficult to distinguish between what is my own decision and what is OCD's decision, to the point where I have trouble knowing what I really want versus what OCD wants. Do you have any advice on making this distinction? Well, if that doesn't sound like an OCD question, I don't know what does.
That will be the signature prototype OCD question of the night.
Yes, absolutely.
So let me start with what you don't do. You don't go up in your head and try to answer that question, because once you do, you're there for the night. Right.
Yeah.
And if anybody has an example of them going up in their head and answering that question in less than 3 hours, please write to me. But that's not what you want to do. And I guess one of the questions that I'm wondering is, why is it important for you to know that? So if you have response prevention guidelines that give you rules, and depending on the nature of the compulsion, what it is, there might be rules about how many per day, what time of day it's okay to do things. So for example, if you are a compulsive prayer and you have guidelines that you worked out with your therapist and possibly with clergy, that the time for you to pray each day is right before bed. And you ask God for forgiveness and blah, blah, blah. And that's all you need to do according to your own religious principles. Then if you are praying any time other than that, that's how you know. Because you have already made a commitment to pray only before bed. And so the principles and the rules are set up to try to make it as clear as possible, because everybody gets confused about this. When is this a compulsion? When is this, maybe is this really something I want to do? Because OCD is really good at convincing you that this is really important to do right now. And this isn't like the other things your good-for-nothing therapist told you. This is different. This is really valid. And it is really good at tricking us into doing that. And then you've got to go back to your rules and say, wait a minute, no, it's not bedtime. I'm not doing it. And that's how.
And I don't know that anyone with OCD has ever actually answered that question to the satisfaction of their OCD.
No, there's that one guy in Montana.
Oh, that guy in Montana, yeah. But
that's it.
But otherwise. Mm-hmm. Now, this is an interesting question. Okay, doctors, what if your OCD unintentionally rearranged your priorities to put your job ahead of your family and it's tearing the ladder apart? How do you get your priorities back to the correct order? P.S. What are tips? We answered that part, right? So they came in late. Now, isn't that interesting? I think there's a problem with that question right off the bat, which is OCD doesn't do anything unintentionally, right? I've never once seen OCD go, oh, Well, that was a happy little mistake, right? It's just like there's so much intentionality in what OCD does that OCD would not unintentionally rearrange your priorities. It would purposely rearrange your priorities.
Yeah.
That's not just going to happen accidentally.
Well, if you know OCD is the thing that did it, I'm not quite sure I understand the problem. Why would you follow OCD
Right.
under any circumstances, especially if it's divergent from your own priorities? And that's the other thing that people have to understand, that more and more we recognize the importance of values clarification and prioritizing and really getting clear about what is important to you and separating that from OCD. But if OCD intentionally or unintentionally arranged your priorities, why are you letting it? You have agency. I mean, I get in a moment it's hard to resist a compulsion. I'm not saying that this isn't really, really tough, but to be able to write out what you think is important to you as a beginning step, and then trying to follow, and you will fail from here and there. We all do. That, and then trying to follow your own values and priorities as opposed to being dominated by the feelings of OCD and its dictates.
Yeah.
By the way, I always love it when a question starts out, "Okay, doctors."
Yeah, right.
Miss Smart ass.
Take that, you smarty pants man.
Yeah.
Have you ever had any luck with ERP and religious OCD? I have religious OCD, also called scrupulosity. And ERP didn't seem to work because all the thoughts seemed to re-energize and come back stronger later. So I can say, yes, we've both had very good successes with scrupulosity and religious-based ERP. And in the aspect of ERP didn't seem to work because all the thoughts seemed to re-energize and come back stronger later, might first tell me that, well, maybe they did work initially, and maybe part of the problem was we didn't stick with ERP. We kind of slid back to doing things that we used to do. That would be my thought.
No, that's a very, very good observation. It's a very likely possibility. But I would also say, yeah, that it almost sounds like they didn't really keep it up and take it out to its conclusion. The other often common problem with scrupulosity is going too fast into ERP. And really it's directly relates to the thing I was talking about a minute ago, that you have to clarify what you truly believe religiously. And there is a process to that that sometimes takes a while before you should jump into ERP. And really committing on paper, here's what I believe. And believe doesn't mean no. It means belief, because faith is not about knowing. It's about believing. That's the definition of faith. In fact, the quest for certainty with scrupulosity is the antithesis of faith.
Correct.
Because if you know it, there's no faith.
You need no faith if you know it.
You don't need it. Faith is a leap beyond what you know. And that's what people with OCD have trouble doing, because they can't stand the uncertainty. And they want to know. And that never happens.
I love a quote that I've been using recently. Richard Dawkins said, "I wasn't alive for the first 14.5 billion years of the universe, and I'm not too bothered by it. I'm also don't think I'm going to be too bothered by what happens after I die for the next 14.5 billion years of the universe as well." So.
Well, you just depressed me, though.
I'm sorry.
I thought I would live that long.
I thought you had lived that long. Hey,
Oh, I come on for this abuse.
Yeah, well, let's see. Could labeling intrusive thoughts as OCD be considered reassurance seeking? If you do it more than once, sure. Yeah. Right.
Yeah. Well, actually, whoever sent that question in, I've heard many a learned scholar argue between themselves about whether you should do that or not.
Mm-hmm.
Whether calling something OCD is perhaps a compulsion, or no, just a useful thing. And I don't come down hard on this, because I kind of what you said, Patrick, really cuts to the quick. Compulsions are ubiquitous in our lives. Or ritual. If we just call them superstitious behaviors or rituals, there's nothing wrong with a compulsion by itself if it's functional. If I can tap one time on a desk and I'm good for the day, if I believe that I'll get good luck if I tap on this desk and I'm good for 24 hours, that's completely irrational, but it's functional. And if I did that the rest of my life, just once a day, like that, I'm good. That's not dysfunctional. It's a compulsion, but it's not dysfunctional. So I think Patrick's point is really, really quite good. It depends on whether it's dysfunctional, not whether it's a compulsion.
Yeah. Our last question, and this is an interesting one. It's about POCD, pedophilic-based OCD, but it could go for anything, really, I think. Orientation, harm. Do you recommend using the maybe I am, maybe I'm not approach?
Okay, so this is another one that comes up in conversations. So some therapists say, I am a pedophile. Others say, I should say, maybe I am, maybe I'm not.
Mm-hmm.
So this, to me, is confusing the effect from the trigger, to get too concerned about this. What we want to do is generate a state of uncertainty in you so that you can learn to move on with your life without having the reassurance, the illusion of reassurance that you know exactly what you are. And it doesn't matter, pedophilic, serial killer, whatever it is. So whatever generates that uncertainty in you will be therapeutic. If saying, I am a pedophile, generates that uncertainty, then that's good. If saying, maybe I am, maybe I'm not, generates that, then that's good too. But it's the state of uncertainty that we're trying to generate, not words. And so either one is fine if it generates the uncertainty about whether you are pedophilic. And that is what you have to learn to live with without trying to control it, and let that feeling go and come and go without it, because none of us know.
Right.
We don't.
But Dr. Pollard, I'd accept that in anything else in my life other than in this one area where I need 100% absolute certainty.
Because it's so horrific.
Right.
Yeah, I get that. But you still can't have it.
Yeah. And I've used the example sometimes when I'm with patients who fear, what if I could harm someone? And I'll ask them if they've ever tried. And almost all of them say no. And I've given this story out on this podcast before. And then I tell the story when I did try to harm someone once because someone attacked my family one time. And when he knocked my mom down, I kind of lost it. And I beat the crap out of him until 4 police officers pulled me off of him. So I'll say to the patient, it's interesting. The most dangerous person in the room right now is the therapist, not actually the patient, because the therapist is the one who did actually try to kill someone one time. So I can't give you any guarantee of what you will or won't be. I can just allow you to be okay with the fact that it could be.
And I've learned something tonight, not to mess with your mother.
That's right. Well, you've met my mom, so you know.
Yeah, well, even by herself, but especially not when you're there.
Right. Exactly.
The crap beaten out of me.
Yeah. Well, Dr. Pollard, it has been a great pleasure tonight. Once again, everyone, this is Dr. Alec Pollard from the St. Louis Behavioral Medicine Institute. He's got a couple of books coming out. You want to tell the names of those again there, Alec?
Well, they're not out yet, so next year I hope. One is called When Therapy Doesn't Work, the 5 Barriers to Effective Psychotherapy and What to Do About Them, or How to Get Around Them. And then the other one is The Family Trap, a guide for those when your loved one won't seek help. So
wonderful. And Once again, our Wednesday night webinar brought to you by NoCD. You can download NoCD on the Google Play Store or the iOS as well. It is a free download. And if you're interested in teletherapy, you can go to treatmyocd.com.